I know that you are ready for instant gratification.
That's right. That's right.
Way to appease us.
All right. I know I was one of those people that I have to know. Back in the day when I went to school, we were lucky to get results in a week and a half. And they posted them for our full Social Security numbers.
On the door.
On the door.
Oh. That's how it was when I went to UNCC.
Yeah, back in the day. So that's why I remember my Social Security number off the top of my head. Also knew my driver's license number for the same reason.
Got your license tag. You know your tag number too?
I do.
Oh, wow.
I do.
I was taught you have to know that.
Now I'm gonna. If you really want to know someone that's really, my husband is one of these people that is just absolutely irritating with how many phone numbers he remembers. I mean, even before you programmed them all in your cell phone, his people would do the phone test. And he could remember people's phone numbers from 20 years ago that worked at his company. And it was one of those things that, you could all pizza, back before you had to order them online, he would always just dial in the number, never had to look it up. Didn't matter which pizza place you ordered it. But I do remember some numbers. All right, so let's talk about amputations today. Basically, one of the things that I'm going to tell you is that the incidence of amputations is increasing. And you're more likely to see that in your nursing care. Not only if you work orthopedics or post-surg or someplace like that, but I'm going to tell you, you're going to see it a lot with your patients. The more our population develops diabetes, the more likely you are to work with someone that's had an amputation. Now, we consider them either elective or traumatic. Now, electives basically, it's not something that you would automatically elect to have done. It's basically you need to have done and elect to have surgery. Basically, that's due to complications of peripheral vascular disease and like PVD. Whenever we have a patient that either does not have good arterial circulation or they have venous congestion. Basically, with people with PAD or peripheral arterial disease, what happens is that mostly due to smoking, you get poor circulation in the legs, and unfortunately what happens is gangrene sets in. Same thing with diabetes. You have, again, poor circulation because you get inflammation in the blood vessels and you develop a secondary infection. Typically gangrene, not gas gangrene, but dry gangrene. I can't even say it now. But what happens is the toes blacken and eventually fall off. Be careful when you're doing dressing changes. These are not dressings that you just want to rip off, especially if you've got blackened toes, because occasionally you will find that a toe will come with the dressing. Traumatic amputation, basically we see quite a bit in this area. Not as much as we used to, because not a lot of people work in the factories or the mills like they used to. But we often would see them as occupational injuries. Not only mill workers, but farmers. Okay, hay balers are notorious for jerking your arm off. So those are things that you have to be very, very careful about. Occupational motor vehicle crashes. Again, traumatic amputations. One night I was working, doing charge in the ICU, and this guy calls and says, "Renee, I got a train wreck for you." And of course, that's slang for everything known to man is wrong with him. I said, "Okay, Curtis, what's the diagnosis?" He says, "No, train wreck." amputation of the right upper arm. And basically, he had been laying on the train tracks. I don't know if he was drunk or what, but amputated his right arm. 2 hours later, I get a call from Curtis again. He said, Renee, you're not going to believe this. I said, what? I got another train wreck. This one is a left amputee. Were they together? No. He was 2 miles down the tracks. So we do see quite a bit of amputations. Well, you know how it is. We put them both in the same room so that they had one pair of arms between them. I still remember these two guys. Both of them not only had the amputations, but they had head injuries, which meant that they could not immediately go to surgery and have their amputations fixed. One was a very high amputation. The other one was right at the elbow. So, which one was more functional? Of course, the one with the elbow. Okay. But motor vehicle crashes, more injuries. We see quite a bit with our service people with IED injuries and other types of injuries. So, in our area, I would say probably the occupational and motor vehicle crashes are going to be the ones that's most often. Typically, one of the things that you will see, if it is a traumatic amputation, if there is a significant amount of vascular injury, they will elect to go ahead and take off the limb instead of trying to reattach. Now, with the level of amputation, one of the things that you will see is that, especially with someone that has either diabetes or the vascular disease, they will try to do as low a level of amputation as they can in order to leave this person with a more functional limb. Okay? Toe amputations may be done if it's just the toes that have good, poor arterial flow and the rest of the leg is pretty good. Typically, a below-the-knee amputation or a foot amputation that leaves the ankle joint, okay, are much more functional. If you can leave that joint, it fits better into a prosthesis. In fact, I was watching some YouTube video from, I don't know, Johns Hopkins or someplace, that basically one of the things that they were doing with kids with bone cancer, and it was really fascinating to look at, that what they had done an above-the-knee amputation, but the foot itself was cancer-free. So what they did was reattach the foot backwards to the leg so that it fit into the prosthesis, and therefore they had a functional joint, and it was much, much better, and they were up and walking in 2 weeks instead of having to learn how to rehab without a joint or use the joint on the prosthesis. It's really sort of interesting. But remember that, you know, below the knee, above the knee, anytime you can leave that joint, you're going to have a more functional limb. And one of the things that you may see with some people, if they have mid-thigh damage, you may see what they call a hemipelvectomy, where they will take the entire limb, including the hip joint, and then the prosthesis has to be sort of like a bucket type thing. So level of amputation will make a difference in how functional that limb is going to be. When you look at some of the complications, hemorrhage, of course, is going to be one of the complications that you're going to see. quite a bit. One of the things that often happens is that you may get some bleeding, either preoperatively or postoperatively. Basically making sure that your dressing is kept dry and intact. Infection is going to be a big key as well, especially if it was a traumatic amputation. Or you have a patient with very poor circulation and you either cover them with antibiotics and the antibiotics are not getting to that area as well. Typically, traumatic amputations also will get that tetanus toxoid as well. Remember, gangrene as a infectious source is found in soil, so that what you will see is an anaerobic bacteria. You will also see a lot of staph or E. coli infections. Now, phantom limb pain is something that you often see after a injury, either traumatic injury or elective amputation. Phantom limb pain is what patients describe as a burning, tingling sensation that, like my toe hurts, but they have an above the knee amputation. Okay? Phantom limb pain is quote unquote not in their mind. Okay? It's not all in their mind. It is a real phenomenon. And it often occurs because of the irritations of the nerves that used to innervate that particular area. Now, with phantom limb pain, typically what we do is we medicate them for pain, because pain is what the patient says it is. You don't say, you'll get over it, you don't have that foot anymore, it can't hurt. Because basically what that's doing is telling that patient, I don't believe you, and there's nothing that I can do about it. Okay? You listen to them, because what you might have to do is medicate them for pain, but you're going to put them on medications like Neurontin or gabapentin, okay, like you do for your patients with herpetic pain or neuropathic pain, like your patients that have that neuropathic foot pain. These patients often will have a decrease in that phantom pain, though I have seen some patients that have it for 20 years and have to have other types of procedures to basically deaden that nerve in order for that pain to go away. Neuromas. Now, neuromas basically are a type of benign growth that will grow on a nerve pathway. It just gets to be enlarged, and it often occurs in your upper extremity amputations. Okay? Now, nursing care prior to amputation, one of the things we're going to monitor is their neurovascular status. Looking at their 5 Ps, okay, pain, pulses, all of those types of things. All right, we're also going to do psychosocial assessment. Think of this as a loss. Patients will grieve this loss of limb. It is a drastic change in their body image. So they will go through that grief process, including denial, anger, bargaining, the whole 9 yards. Okay? So it's not unusual for them to yell and scream and complain that if someone else had done something, then I would be keeping my leg. Okay? So those types of things you need to think about. It is, unfortunately, one of the things that we often see that the nurse, because we are the person at the bedside, we are often the person that gets yelled at the most. Okay? Or their family. You will see that often their family has to be supported because they are the subject of this person's anger. And it's just because of displacement. Because they're losing their limb, they displace that anger onto someone else. Now, you may see these done diagnostically, an ankle brachial index. Basically, what they will do is they'll do a blood pressure in the ankle, and then they do a brachial pressure, and then there's a ratio that you look at for the difference. Okay? So what you will see is that if you have circulation problems in the ankle, but you have none in the upper extremities, then that index is going to be higher. And what you're going to see is that it shows you that that does not have very good circulation. Okay, ankle brachial index. Usually it's not something we do, it's usually something done in radiology. It's also done as part of an ultrasound because they will look at Doppler blood flow. Any of you ever had to use a Doppler to check for pedal pulses? Yeah. Sometimes on these patients you will, and sometimes you will not find them even with a Doppler because their blood flow is that. Now, traumatic amputations. Call 911. You need the ambulance there because they are the people that will take them to the appropriate center. Okay, I've seen all sorts of amputations, circular saws, traumatics from automobile accidents, etc., etc. One of the things we want to do is to elevate the extremity above the level of the heart to decrease the bleeding. Now, do we automatically want to put it on the tourniquet? No. Depends on how much bleeding. Now, if you've got arterial spurt like this, then I would recommend a tourniquet. But one of the things we don't want to do is to cut off all blood flow. Okay? One of the things that you also want to think about is, do you think that this limb could be reimplanted? A lot of times they will do fingers, toes, and hands, feet. If they're taken to a center that will do reimplants, you're talking Duke, UNC hospitals, or the Baptist. Okay, you're not talking about here at Rowan or Northeast. They have to go to a center where there's an orthopedic and vascular surgeon. Now, a couple of things you need to remember. Am I going to make that decision about reimplants in the field? No. What I'm going to do is take that limb or toes or whatever it is, put it in a plastic bag, stick it in ice water. Okay, you don't want to put it on ice, but ice water, like a slushy water, and send it with them in the ambulance if you can. If you don't find all the fingers and toes until later, you still bag them up and have someone send them to the hospital. Now, if they're able to reimplant, we're talking about a long-term process because one of the things that you're going to see is that they will have to make sure that they have good circulation. They not only have to reimplant and line up bone, but they have to line up and make sure that the blood vessels are perfusing that area. Now, one of the things that you will see is that after reimplant, a lot of times what you will see is a lot of venous congestion. And it's an old type of remedy, but it works like a charm. What we use to get rid of that is leeches. Leech therapy. we don't go out in the river and get them ourselves. They come from Carolina Biological. And basically what you do is you take the leach out of the little container and place it on the limb, and they will attach. And whenever they get full, they'll fall off. You take the leech and put it back in its container because now it's a biohazard. Okay? So typically those are collected and are disposed of. But just everyone, keep the leeches on the hand or wherever the reimplant is to keep that congestion down. Now, 2 words of caution. Don't try to pull it off until it's ready to come off. Because if you pull, you better have a full mask on and face shield on, because they will pop. Okay? And they get blood everywhere. So just let them attach, and they'll fall off whenever they're full. And if you need to, just put another leech on. Okay? But with reimplants, it's very, very important to make sure that you assess those 5 T's. We want to make sure that they've got good circulation. We want to make sure that that dressing is clean and dry. Our incision site is without redness or swelling or drainage. We want to make sure that the stitches look appropriate. Okay? And I'll tell you, getting stitches out of those are usually very difficult because they use those plastic surgery sutures. And they're tiny, tiny, tiny sutures. But best thing you can do is just send it with them in that iced water. Okay, don't put it directly into the water. It needs to go into a bag. What we want is the monitor for sufficient tissue perfusion but no hemorrhage. Okay? We want to make sure that that residual limb is pink but not discolored. And this is going to be after any type of amputation. Okay? It should not look dusky. It should not look gray. It should look what's appropriate for their skin color. It should be so that if you blanch the tissue, that it either pinks back up or becomes to the normal color, skin color. We want it warm, but we don't want it hot. Okay? Whenever you feel that skin, and typically I feel like that mom feel with the back of your hand, okay? When you're checking your kid's temperature, basically you want it to feel like the surrounding tissue, but you don't want it to be hot because hot can indicate infection, okay? Proximal pulses, and you may have to use a Doppler for that, because if I have had toes amputated on this client, then I'm going to check basically pedal and as well as popliteal pulses on this patient to make sure that they still have good blood flow. If it's a hand amputation, I'm checking brachial and axillary pulses and making sure that they've got good blood flow. Now, again, let's talk about phantom limb management. Typically, one of the things that you will see is that often they will infuse IV calcitonin. IV calcitonin will help decrease phantom limb pain. They may also use beta blockers. Okay, and what do we typically use beta blockers for? Blood pressure. Okay, remember these are your laugh out loud drugs. Okay. Laugh out loud drugs. LOLs.
What was the last part?
Metoprolol and all of those laws. Okay. Basically, beta blockers can be used as part of pain management. But if I am using a beta blocker as part of my pain management, what am I still going to teach this patient about? watch their blood pressure, but how else am I going to tell them if they're sit up slowly? When would I hold the beta blocker? Pulse rate is less than 60. Okay? This is one of the little things that you need to know about. You know, when I don't know if I told you about when I went to the when I had my hip problem, I went to the aerobic class for the elderly, and she was telling them to get 120 on their blood. Well, most of them were on beta blockers. Okay, and their resting pulse rate was 70. If you take someone with a resting pulse rate on a beta blocker and get them up to 120, they're going to be in the floor. Okay, so these people will always have that low blood pressure because of that beta blocker that they're taking for that pain. If they have knife-like or sharp burning pain, they will take anti-epileptic medications like Dilantin or phenytoin. Okay, they will take Neurontin or gabapentin. Gabapentin, even though we use it in lower doses for pain management, is really an anti-epileptic drug. So it is one of those medicines that I never would cold turkey someone off if they've been on quite a while, because they can seize, even if they have no history of seizure. Even though with gabapentin, typically what you're going to see is 100 milligrams up to 300 milligrams 3 times a day for pain. Well, as seizure medicines, we give up to 1,200 milligrams a couple times a day. Also found out that they use gabapentin for sedation in cats and horses. Interesting. Anaspasmodics, a lot of times muscle spasms can be a cause of pain and will contribute to that phantom limb pain. Some of your anaspasmodics are your dantrolines or your baclofen to try to decrease that. Typically, we shy away from meds like diazepam or Valium. Okay, because remember, this is going to be a long-term issue, and you don't want to put these patients on benzos long-term, because the risk for addiction is truly real. Other treatments: massage, heat, feedback, hypnosis, psychotherapy. Not because the pain's in their head, it's helping with pain management. Okay. Now, the heat, the massage, definitely this has to be done after that residual limb is well healed and you have a good incision, because you do not want to rub or to massage that residual limb without it having a good closure of that incision. Okay. Nursing care, prophylactic antibiotics. Typically what you're going to see is it depends on whether this was a traumatic or an elective. If the site was infected, because we often will do amputations for osteomyelitis as well. And if the amputation was for osteo, then you may see antibiotics or IV antibiotics for 10 days or more. Okay? The majority of time, if it was traumatic or an elective, they will do them like an hour before and 3 to 4 doses afterwards, just like they would with hip replacement. Typically what you're going to see is those drains that they put in place to decrease some of that swelling will be removed in 48 to 72 hours. Now, a lot of the physicians that I've worked with like to keep the antibiotics in place until the drains are removed, okay? But the American Association of Orthopedic Surgeons say that that's not necessary. So it will depend on your physician. Pressure dressing, Remember whenever those of you that were in simulation this past week, we learned to do that pressure dressing? And what you're doing is wrapping that residual limb with an ACE wrap, keeping the pressure tight at the bottom and lessening at the top. Because what we're trying to do is push edema and venous blood back up that leg. Remember one of the, that light keeps going on and off. I think the ghost is, yeah, I think it's just because there's no one out moving in the halls. But anyway, back to this. The reason that we have venous return back to our heart is that because the pressure of the muscles on our leg pushes that venous blood back up. There are valves in the legs that keep it from flowing back. Whenever you remove that muscle pressure, you will have venous stasis. Okay? So one of the things we're trying to do with this pressure dressing is to keep that pressure so that that blood will return back to the heart. Now, pressure dressings are usually done not only to reduce the edema, it helps decrease sensitivity, and it helps to mold the end of that residual limb so that they can be fitted with prosthesis. Typically what you're going to see is they're fitted with that prosthesis at about the 3-month mark because it's well enough healed, the sensitivity is decreased, and the shape of that residual limb is sufficient to go with that prosthesis. We want to promote mobility on these patients. We don't want to amputate their leg and then leave them in the bed to develop all sorts of other complications of mobility. PT is an excellent consult, and it should be written as a post-op order. If it's not, check and see why. We want to do range of motion to prevent flexion contractures. Now, elevation on the pillow will depend on your doctor's order. Typically, you do not elevate if it's a lower extremity amputation for more than 24 hours. Because if you think about it, when you elevate that limb, it strengthens these muscles so you get flexion contractures so that they will not be able to leave that leg down. What you're going to see is that you want, after the first 24 hours where you're reducing the edema, that leg needs to be flat on the bed. And in fact, one of the things that you want them to do as part of their PT is to push that leg into the bed, okay? To tighten their quadriceps muscles, to push that leg into the bed, and that helps to relieve and reduce the chance of development of that flexion contraction. This is another key point. With someone with a lower leg amputation, we're going to position them prone about every 3 to 4 hours for 20 to 30 minute periods, because putting them belly down basically will stretch out those muscles in the back of their thigh. So what you want to do is place them prone so that it stretches those muscles and keeps them in a more neutral position. And this is something they're going to do throughout their rehab and throughout probably the rest of their life. This is the instructions that they're given, like flat on your stomach, support your head and your arms with pillow, natural limbs stretched out straight, keep your hips flat on the bed, try not to twist or raise your hip on the residual limb side. Breathe deep and relax, letting gravity stretch those hip muscles. You want to hold it for 30 minutes and then repeat 3 times a day. These are the instructions that they're given on proning these patients. One of the things that you'll also see that not only does this help relax the hip muscles, but I will tell you that it also helps the lungs. When you look at prone position, it will help reduce atelectasis. Though I will tell you in the ICU, it's a nightmare because if you've got all these tubes and lines trying to keep someone prone for 30 minutes and keep up with what's going on, it really, really is problematic. Now, skin care, wash the limb with mild soap and water every day, pat dry. This is something we don't want rub. Check the limb for red pressure patches that last more than a few minutes. Skin breakdown at least twice a day, we're going to look for it. Okay? Do not use talcum powder or any type of powder on your limb as it can ball up, create an abrasion. Okay? This is something that we don't want them to put anything on that limb. Alcohol, chemicals, creams, or lotions are not to be put on that residual limb. They should not shave. Okay? If skin opens, they should go straight to the doctor or prosthetist. Okay? This is the person that does the prosthesis. A lot of orthotics and prosthetics. Remember, soap and water, pat dry, and that's all we're going to do to it. Okay? With prosthesis, we're going to wash anything that makes skin contact, like our liners, the socks, the inside of the socket every day with mild soap and water, and allow plenty of time to dry. Most of your prosthesis are sort of going to be conical in nature. So we need to make sure that that little bottom piece gets very dry because you don't want moisture in there because it can contribute to skin breakdown. Know where your landmarks are. Where should this portion of the prosthesis line up with that residual limb? The person that fits the limb, somebody want to try it, will show you. If they lose weight or gain weight more than 5 pounds, they should have their prosthesis rechecked for fit. Because either losing or gaining weight, having that residual limb sort of mashed into that prosthesis, or having it loose can contribute to skin breakdown. It's like whenever you wear too big or too small shoes, okay, you're going to get blisters. Same thing with this prosthesis. Make sure your shoe height is correct for your prosthesis, or your alignment will be wrong. You want your shoes to match. Most people buy one shoe and leave it on the limb, though some people will change. The other day we had this guy, he had a pair of Brodans on. I mean, it looked like Timberlands on his prosthesis. So it was, most people wear sneakers or dress shoes. I've seen one lady with high heels, but she had to wear a heel that matched the height on the other top, because you don't want to be doing this because of the height of your shoes. Okay? One of the things you're going to see is that leg bag, like things you would need in an emergency, like extra stump socks, full socks, bandages, any antibiotic ointment, and a histamine ointment. One of the things that you're going to see is that the fit of the prosthesis changes during the day, so add socks when needed. Now, what do you think this fit's going to change if I've got someone with a AKA and they have a prosthesis? how do you think that fit's going to change? What's it going to be in the morning? Smaller. So you're going to have extra socks on. And then as the day goes on, you know how your feet swell whenever you stand on them long periods of time, that leg is also going to swell. So you may have to take those extra socks off towards the end of the day. Okay? So that fit will change. If they're having trouble with the prosthesis or liner, don't make their own adjustments. They should have the professional to take a look at it. And one of the things that you'll see is that it is very, very important for them to know their person that deals with their prosthesis, because they may have to have more than one in their lifetime. Think about kids that may have to have an amputation for bone cancer. All right? As that child grows, they're going to have adjustments or even changes in their prosthesis, because you don't want that prosthesis not to be like my canes where you have that pop, 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 you know, to change it like that, because it has to be more stable. So often what you will see is that they will have to make adjustments. So the first prosthesis that they may be fitted with may not work very well, and they may have to go to a different kind. Now, with people with above-the-knee amputations, typically they will give them a prosthesis for the joint at the knee, because it allows for more normal movement. However, what you're going to see is they're going to have to work with physical therapy to figure out how to move that joint so that they would have more normal movement. Without the joint, it's like walking stiff-legged, okay? So their gait's going to be a little different. The guy that we had on the unit that had lost his leg in a motor vehicle crash, it had been several years. And like I said the other day in Sim, if he hadn't had on shorts, you could not have told that this was he had an artificial leg based on his gait, because his gait was so normal looking that he'd gotten so used to his prosthesis that you couldn't tell, okay? But I would imagine that he went through a lot of physical therapy and a lot of practice to get that normal looking gait. Any questions about amputation? All right, let's take a 10-minute break. Be back a quarter after, and we will start